Well, good evening and welcome everyone. Thank you so much for joining us for another wellness webinar series event with Jefferson Health. My name is Sarah Breckbill and I will be serving as your program facilitator and will present your questions to our experts. Tonight, we'll learn all about this cutting-edge surgical technology, including how it works, the benefits, what procedures can be done robotically, what to expect during recovery, and much more. Well, thank you so much for submitting your questions in advance of tonight. And the questions that you'll hear me asking the providers are all submitted right from when you registered for this webinar. Now, if you have any questions throughout our discussion tonight, for those joining us on your computer or tablet, at the bottom of your screen, you'll see an icon that says Q&A. We'll do our very best to get to as many questions as possible, but may not be able to answer all of them during this virtual event. And due to hospital, university guidelines and privacy, we are unable to comment on specific cases. Well, without further ado, I want to go ahead and introduce our experts for the evening, starting with Dr. John Phu with general surgery and Dr. Paul Minkovich with general surgery. Well, thank you both so much for joining us tonight. And I'll go ahead and give each of you a minute or two to say hello and give a little background information about yourself. So Dr. Phu, we'll go ahead and start with you. How are you doing this evening?
Sure. Thank you, Sarah. Thanks for having us this evening. Much appreciated. Thank you, everybody, for joining us tonight. A little bit about myself. I'm from Canada, Toronto, Ontario. That's where I did my bachelor degree. And then I came over to Michigan State University for my medical degree. And then from there came to Abington and did a general surgical residency. After graduating from that, I came to Lansdale and did general surgery practice since then.
All right. Well, thank you so much for joining us. We're excited to have you here. Dr. Minkovich, thank you so much for joining us. And how are you doing this evening?
Hi, I'm doing well. A little bit about myself. So I grew up in actually the Bucks County area. I went to Temple University undergraduate and then Philadelphia College of Osteopathic Medicine for medical school. Graduated 10 years ago now, which seems crazy to think about. Did residency at Philadelphia College of Osteopathic Medicine and Suburban Hospital. And then since graduating, I spent the last 4 years, I was at St. Mary Medical Center. And then I started with the team here at Lansdale about 6 months ago. I'm happy to be here. And thank you for hosting tonight.
Absolutely. We're happy to have you. Okay, well, I know that we have a lot of questions to get to that were submitted ahead of time. So I'm excited for an exciting discussion. So let's go ahead and just dive into the questions. So question number one, Dr. Phu, this one is for you. How does one know that they need to talk to their doctor about surgery? And when is surgery considered to be an option?
Sure. Yeah. I would say since this talk is about gallbladders and hernias, we'll kind of divide those two topics and see what is indicated for what. But regarding hernias, I mean, specifically inguinal hernias, there's about 20 million repairs that are done worldwide. So it's a very common procedure. And, it's dependent on the patient's symptoms. For example, if somebody has an inguinal hernia and it's small and asymptomatic, it's not bothering them, then watchful waiting can be a safe choice. There's no increased risk of an emergent operation. It's about 0.2%. However, when it gets to the point where the hernia gets larger in size, or perhaps impeding some of a patient's daily activities or life, like bending and lifting causes some pain, coughing and sneezing, it exacerbates or aggravates their symptoms. Those would be indications for an elective hernia repair to avoid, risk of incarceration and alleviate their current symptoms. And of course, there can be situations of an emergency when a hernia gets incarcerated or gets stuck, and then they end up in the emergency room. But most of the time, you want to try to get to them in the outpatient setting, evaluated in the office, and if indicated, scheduled for repair. Similar for umbilical and ventral hernias. Small ones can be watched if it's not bothering them or very minimally symptomatic, but a watchful surveillance would be a good idea in case they do get bigger or more symptomatic. Now, in regards to gallstones, About 25 million Americans have gallstones, but not all of them are symptomatic, and most of them are silent, meaning they don't cause issues or pain or get lodged. About 800,000 gallbladder surgery, I should say, are done each year. So, like I said, most are asymptomatic and stay silent. So, if they don't cause problems, meaning it doesn't, precipitate with fatty foods or your diet or cause, colicky pain in the right upper abdomen, then they can be watched. However, about 20% of those who have stones can develop these symptoms, and that would be, colicky pain after fatty foods, pain that radiates to the back, lasts 30 minutes. Sometimes it wakes patients up from sleep, and sometimes on occasion it's bad enough that they end up going to the ER for a trip because of the severity of pain. So those would be indications for symptomatic gallstones for surgery to be removed.
Okay. Well, thank you so much for walking us through that. Let's move on to the next question, talking a little bit now about recovery time. So Dr. Minkovich, what is the general recovery time from traditional hernia repair versus with robotic repair?
Sure, and thank you for the question. I usually, when I talk to patients in the office about hernia surgery, I kind of break that down into two things. And I think, the thing that will be the main difference for robotics versus open hernia surgery is how the person feels after surgery. Now, we're doing robotic surgery, meaning incisions are much smaller than a big incision in the groin for an open procedure. Typically, advantages of robotic surgery, less blood loss, smaller incisions, and ultimately less pain. So, I find that most people, maybe a couple days of discomfort and they feel more or less back to normal. Certainly, I would say by a week or so after surgery, the majority of patients that we do robotic surgery on feel pretty good. So I think that's kind of the main advantage. The thing that, is difficult to sort of change is with hernia surgery specifically, there's a little bit of a built-in time of limiting activity such as heavy lifting, and kind of doing anything too strenuous. And that's just part of the healing process to allow the surgical site to heal and not to get risk another hernia. And I wouldn't say that there's necessarily a huge difference in that recovery, because ultimately it is a similar procedure in terms of what we're fixing. But in terms of how the patient's going to feel, I think it does definitely reduce recovery to, feeling back to normal and being able to get back to your normal activities of daily living. So I think that's the bigger advantage that we're going to see.
Yeah, absolutely. Exciting to hear. Okay. Next question here, Dr. Phu. A few more questions that were submitted about hernia surgery. So can you just talk a little bit more about hernia surgery, recovery risks, downtime, and even post-op? And we're also getting the question, is the surgery typically covered by insurance?
Yeah, sure. Those are great questions. But since we're sort of leading into this robotic explanation, I think it would be a good time to pop up some slides to discuss what the Da Vinci surgical platform looks like and kind of explain some of the tools here. So this is the Da Vinci robotic surgical system. It is the prior generation, the SI, although we do have the current generation XI, but this concept is the same. So this is the patient cart, and these are the 4 robotic surgery arms. You can see it looks very big and intimidating, but down at the tips there is kind of where the small instruments operate and give the surgeon full dexterity. This is what is, at the patient bedside where the surgery is performed. Next slide. So it consists of 3 parts, so to speak. The one on the most left is called the surgeon console. You can see where they would the surgeon would sit down. The clutches, you don't see that on that picture there, but that's where we would operate and put our fingers in to control the movements of the patient cart. And we have 3D high def cameras to see every detail of the surgery itself. And then the far right is the vision cart. That's where all the instruments plug in, get their electricity, and also kind of generate the image itself. So all 3 of those come together to be the Da Vinci surgical system for operating. Next slide. This is just another view of how it looks like in sort of real life or in the operating room. The surgeon is at the console, and we're not, at home or some remote location. We are in the room itself and very nearby. But you can see that the surgeon's hands are at the finger clutches doing fine dissection, and that translates immediately to the robotic arms that are in the patient's body for whatever procedure that may be. Next slide. This is just a comparison of how sort of small and fine these instruments are. So that's a number 2 pencil, and that's a scissor. That's one of many instruments, of course, but they are of the same sort of caliber and size. They can be fenestrated bipolars, they can be hook cautery, needle drivers, and they're all of equivalent sizes. And it fits to the sort of girth of a number 2 pencil through these trocars, through the abdominal wall to do these fine dissections. So one of the main advantages compared to open and laparoscopic surgery is, of course, like Dr. Minkovich said, smaller incisions, but also the dexterity of the movements that what you could traditionally do with an open procedure with your hands, translates to finer, smaller, precise movements in the robotic instruments. Next slide. It's just to show that robotic instruments have 7 degrees of motion to left, right, pitch, in and out, turn, and can be as much or if not more than the dexterity of the human hand. Next slide. That's just another demonstration to say sort of how our finger clutches, at the console will translate intraoperatively, as that's what we see on the screen above, whether we're sewing, we're dissecting, we're cutting. That's the vision we see intra-abdominally for the procedure itself, and we can see very fine dissections. Next slide. And that's just an example of an inguinal hernia repair. That's kind of the end product, so to speak. Once the myopectineal orifice is dissected and all the hernia spaces are cleared, a large preformed piece of mesh is placed across the orifice, and then the peritoneum is closed to hide the mesh within. Next slide. Oh, that's it. Okay. So back to your question, Sierra, about recovery risks, downtimes. Typically, when I have a conversation to consent my patients in the office, I say there's always, with any surgery, risks of bleeding, infection, injury to surrounding structures. Specific to robotic surgery and hernia surgery, I would mention bowel injury, sometimes bladder injury. That's some of the organs that are in the way there. Of course, we'll take care to dissect things safely and not injure things inadvertently, but those can be known risks, and also risk of recurrence. So despite our best efforts, data does show that there is a small risk, about less than 1% of recurrence rates for hernia repairs. To the question about, is it covered by insurance? Yes, is the short answer. Da Vinci Surgical Systems is considered a type of minimally invasive surgery. And so therefore, most insurances do cover Da Vinci surgery as a type of minimally invasive surgery.
Okay, well, thank you. And really fascinating to see those pictures live on the screen. So thanks so much for sharing those, and cool to see that in action. So thank you.
Sure.
Okay, moving along here, Dr. Minkovich, let's turn back to you. Question about, is robotic surgery a same-day surgery? And what about for different kinds of hernias?
Sure. So I would say, in my practice, that almost everybody is a same-day procedure for robotic surgery. Now, obviously, there's always exceptions. I don't usually plan to keep patients unless there's some unforeseen issues, whether that's anesthesia reactions, uncontrolled nausea, things like that. But assuming everything goes according to plan, almost everybody goes home. Regarding various types of hernias, the hernias that we do at Lansdale, I think we're all pretty good about same-day procedures and trying to keep people in the hospital as little as possible. Looking at the questions before the webinar, there were several questions relating to hiatal hernias, and I just wanted to point out that we don't do those at Lansdale. That's a different special type of hernia that's usually done by bariatric surgeons. They do them at Abington Hospital, but we don't do them at Lansdale. Those patients do end up staying in the hospital from my training. but that's a special type of hernia that we don't do. But I think we all have a pretty good effort to try and get patients home the same day with these types of procedures.
Okay, great news. All right, next question, Dr. Phu. Would you be able to just talk us through the advantages and disadvantages of robotic surgery?
Sure, yeah. I already touched upon a couple of points explaining the system itself, but of course, one of the advantages is smaller incisions. Dr. Minkovich had mentioned, with smaller incisions, typically associated with less pain and therefore less need for narcotic use. A lot of times my patients, and Dr. Minkovich can attest to this, they can manage through with, Tylenol and Advil around the clock for the first day or two. I give a small script of oxycodone narcotics just in case they need something stronger in between. But for the majority, for the most part, they can get managed with non-narcotics. So I think with small incisions, there's less pain. As well, with small incisions, there's less risk of surgical site infections. Although it is overall small, but with a smaller cut, then there's less risk of having an infection in the area. Specific to the procedures itself, advantages of robotic surgery for, say, inguinal hernias. If an inguinal hernia was repaired as in an open fashion in the past, in an anterior approach, then a robotic repair for these recurrences would be good because it's in a different type of hernia plane or the preperitoneal space. And so that would be more indicated for that type of dissection. It'd be advantageous in say bilateral inguinal hernias. You don't have to make an extra incision on the right and left to fix both sides. You are able to access both groins on the right and left to fix both sides concurrently, if it was indicated, of course, to fix two hernias if they had something like that with the same number of incisions. And so those would be two key advantages for that. Obese patients, to a certain extent, is helpful for the robotic system because it does help kind of the surgeon itself in terms of ergonomics do a dissection without having that extra factor to deal with by the bedside. And then finally, with the 3D high definition camera, we're really right up to the anatomy, looking at even cell layers and vessels and tissues very clearly, and we can very accurately dissect and precisely know what structures to cut when we're doing these hernia repairs or gallbladder surgery itself. So better dexterity, better vision, helps eliminate any tremors by the surgeon itself. Some disadvantages, I would say in general, to have robotic surgery done, of course, the patient has to be, fit for general anesthesia, because if they can't, undergo general anesthesia, then that is not possible to have robotic surgery. Of course, sometimes people talk about costs as a con for robotic surgery. It has been, increased costs for the instruments and the materials, although those costs have come down in general over these, several 5 to 10 years with changing business models.
Okay. Well, thanks for talking us through that, both advantages and disadvantages. Okay, Dr. Minkovich, this next question is for you, focusing a little bit more on reoccurrence. So can hernias reoccur, and will one need multiple surgeries for hernia repair?
Sure. So certainly hernias can reoccur, and I think kind of the longer we go out from an initial hernia surgery, the higher risk we get to having hernias kind of come back. I would say traditionally somewhere in the range of 3 to 5%. As Dr. Phu mentioned, I think we're getting closer down to like the 1% mark with these really good minimally invasive robotic type of surgeries. So it's unlikely, but not impossible. Usually for hernia surgeries, these are, I guess, what you can describe as a one stage or a single procedure. There shouldn't have to be multiple procedures, barring obviously complications and things like that. But it's uncommon to have recurrence happen soon afterwards where we're talking about needing another surgery. Could it happen 10, 15, 20 years down the road? Certainly, that's always a possibility. And some of that is also, patient risk factors. I always counsel patients, not that we're seeing as high of a rate of smoking as we used to, but Tobacco use and smoking remains a big risk factor for hernias coming back. And then the other thing is just excess body weight. Just puts more pressure on the tissue. So even after repair, it puts you at a little bit of an increased risk. But ideally, we are looking closer to about 1%. So they're generally safe and very good repairs that don't have problems down the road and don't have recurrences. But can it happen? Yes. Is it likely? No.
Okay. And a quick follow-up question for you here. Can an existing mesh that has failed be repaired robotically?
Sure. Yeah, and I think that that's kind of in the same vein Dr. Phu had mentioned. Again, if it's something that was done, it doesn't matter how long ago. I mean, 5 years ago or whatever, but it can be fixed robotically no matter how it was done. We are seeing, or at least I think I'm seeing, more patients that had open repairs coming back with a recurrent hernia. And it is nice to do it robotically because you're avoiding all the scar tissue from that initial surgery. So in that sense, it's almost a easier procedure because you're not going through scar tissue. But I've definitely done recurrent hernias that had them done laparoscopically in the past, and there is scar tissue there. But I think the advantages of just the high def 3D vision and the instruments make going through that scar tissue a little safer than when we used to do it laparoscopically with kind of 2D vision and instruments that didn't have as fine motion on it. Was a little more risky for things can get stuck in the scar tissue, whether that's nerves or blood vessels, and you can with the best intentions divide something like that because it's all scarred together. So I think it's a lot safer to do it robotically than laparoscopically for sure. And if it was done open, to go back in through that tissue is very risky because of all the scar tissue. So definitely can be done that way. Yes.
Yeah, just to piggyback on that, I mean, redos are just difficult in general. And so if there's a modality or a way to do it in a plane that wasn't sort of violated before, with the robot, then absolutely it's a better procedure and sort of less chance of injuring other things. But yeah, redos, although infrequent, can be very difficult in general.
Okay. Well, thank you both. All right, moving along to our next question, but first a quick plug that feel free to submit any live questions as they pop up for you during our discussion. We'll be getting to the live questions in just a bit, so feel free to submit those in the chat. But for now, our next question here, going back to talking about gallstones. So Dr. Phu, can you explain just a little bit more about gallstones and can they be removed robotically?
Sure. I think we'll couch that answer, can they be removed robotically? I think that probably lends to cholecystectomy. Yeah, gallstones, like I mentioned earlier, they form, within the gallbladder, of course, due to the stasis or just the bile sitting in the gallbladder itself. And so they can crystallize from the cholesterol or the pigment, I call them pigment stones as well. So those are the main components of gallstones. Like I said, majority are silent, but when people get symptoms from them, they're diagnosed on ultrasound, which is the most sensitive, and sometimes on occasion on CT scan, you can find them as well. And then when we get to the point where it isn't indicated to have it removed because it's causing symptoms, yes, they can be removed robotically, but I would say that a cholecystectomy, or the removal of the entire gallbladder, not just the stones itself, is what is done as a standard. There's no, it's not a standard procedure to just remove the stones itself. I think removing the entire gallbladder and also eliminating that risk of developing stones again in the future is what is the standard of care. There's exceptions to that, of course, but in general, a full cholecystectomy is indicated if necessary. And so I'll ask Chelsea to bring up that slide there. For robotic surgery to remove the gallbladder, cholecystectomy, typically the patient is under general anesthesia. They have 4 small incisions made on the abdominal wall where the robotic trocars and instruments are placed. And then, we inject what we call indocyanine green, or ICG. It's a type of dye that binds to the proteins in your blood and then is excreted in the biliary system, your liver, and then the bile ducts. And so it lights up everything green appropriately. As you can see on that picture there, the liver on the background there is green. And so a bit of the gallbladder you can see is green too as well, where the grasper is holding. And yeah, and it kind of leads down to the cystic duct. And it takes some time to get to this dissection where we're clearing the cystohepatic triangle of the fat and the tissue. And then once we isolate the duct, we clip that and take the gallbladder out. And then so ICG, this dye that we give preoperatively, is very helpful in the dissection of gallbladders, as it helps identify critical tissues, and helps sort of guide the surgeon to dissect in a plane that's safe and known, by lighting up the structures and seeing what's what. So I think there's a definite great advantage for cholecystectomy when using it in the robotic platform is this ICG. As you can see, it's almost like having night vision or a heat map to see where you're supposed to dissect, and really helps increase the safety of cholecystectomy. So final answer, yes, you can remove them robotically, but it would be a cholecystectomy.
Okay. Yeah, and interesting to see that green light effect. So thanks for sharing. Okay, next question here, Dr. Minkovich. A question that a few people have, what happens if the robot malfunctions during surgery?
So, I mean, it's a good question. I will kind of, I will say in the 385 or so robotic cases that I've been involved with as an attending surgeon, and even hundreds that I did as a resident, I've never seen the system completely break to the point where it's unusable. But for the sake of discussion, I mean, there are kind of fail safes built in. So if an instrument, let's say, breaks and we're not able to remove it, there are mechanical releases on the instruments where you can put a special tool in there and kind of release anything it's holding and remove the instruments that way. If the camera breaks, I mean, we have multiple other cameras and things like that. So most of it should be something that we can troubleshoot within the operating room, and it might add a little bit of extra time, but it shouldn't be, some major issue. The worst I think I've seen some of the robotic arms need to be repaired, but it's something that you would notice beforehand, and they can even replace the entire arm if they need to. So it's never been a huge issue from anything that I've actually experienced. But worst case scenario, I mean, let's say that the robot just completely breaks. We would either complete the surgery laparoscopically, or if, depending on the situation, if we needed to, our fallback is always an open procedure. So if we needed to make an incision and kind of get in there, and look at the tissue, and, remove any instruments or anything else, we could certainly do that. And that's always on our consent forms, that there's always a possibility of having to do an open procedure. But again, in the 380 something that I've personally done, I've never had the robot just completely break like that. So it's a good question. It's a fair question, but I would say that, it's something that we check all the time, make sure everything is in tip-top shape, and normally small errors we spot well ahead of them becoming a big problem that would lead to some, major problem like that.
Absolutely.
Yeah, like Dr. Minkovich said, it's very rare. There's usually, I believe, quarterly checks by, Intuitive to come and make sure things are still working fine. It's a very sophisticated, intelligent machine that does a lot of self-diagnoses, and anything that is off or askew usually is warned well beforehand. And even if, say the power goes out or something, there is enough of a battery backup in the system itself for like 8 hours, I believe. So there's a lot of fail safes and backups, and a very rare occurrence if something completely fails. But our team is prepared for plans B, C, and D. So
Absolutely. Always helpful to hear those backup options. So thank you. Okay, Dr. Phu, question for you. I think we have 2 more questions before we turn to our live questions from the audience. Who is an ideal candidate for robotic ventral hernia repair?
Yeah, I think that's an excellent question, and I think it kind of addresses like which are good candidates, I would say. Some of the points Dr. Minkovich has mentioned earlier, we want our patients to succeed. We want the repairs to be sound. We want good outcomes. I think those are all the same surgical principles we all want to be successful with and our patients to experience. And so we need to find ways to make sure our patients are optimized preoperatively. Namely, number one, BMI is a significant factor for recurrence rates. And so, for umbilical or ventral hernias, for a patient, typically in my practice, I would say if they're over BMI 40 in general, I would ask that, they try to lose weight to get it below 40 because the recurrence rates above a BMI 40 is 40% or higher. So if you can bring it down to the 30s, there's a better chance of the repair, holding and being more durable. The other factor for a good candidate would be, stop smoking if you are an active smoker or vaping. That does impair tissue healing. So you typically try to stop smoking for at least a month for both lung function and postoperative healing. Diabetics, if their A1Cs are not under control, they have to be better moderated or better controlled to get them to a good level. And typically, if the A1Cs less than 8, that's a good level to do hernia surgery. So a couple of those factors, I think those are the main ones we look for to make sure a patient is a good candidate or patient for hernia surgery, both robotically or even open as well. But those would be the sort of ideal characteristics.
Okay, thank you. And with that, I think it's actually a great time to turn to our live questions. So let's go ahead and kick it off. And whoever wants to answer, feel free to just jump in. But the first question we have here is, does it take a long training time for someone to learn robotic surgery?
Sure, I can jump that question off. So at least, I would say for me, robotics was starting to become part of our medical kind of training in residency. I mean, I think probably about 50 cases or so minimum, for someone to feel comfortable with the robot, the techniques and everything else. But I mean, as a resident, I was exposed to probably hundreds of robotic cases. So does it take a long time? I mean, sure, like learning anything new is going to take a while, but I think there's a pretty large exposure in medical training these days. It is, not just general surgery, gynecology, urology, so many different, specialties are now doing robotics that I think that we're exposed to it in so many ways that there are additional training opportunities available for sure. And the company Intuitive that makes the Da Vinci platform, they offer trainings all the time as well. But I think, just like anything else, repetition and, kind of seeing the surgeries, doing the surgeries is the main thing. And, I was exposed to it a lot as a resident and, I've been doing it for 4.5, 5 years now. And, I have almost 400 cases under my belt. So it's just, seeing and doing.
Yeah, like I think robotic surgery is the next generation of laparoscopic surgery with better instruments and better visualization. As it's here to stay, and I think it becomes more widespread. The trainees and training programs, and that has been disseminated very well, so that there is much more a guided path in terms of learning and adopting these technologies. And of course, there's a learning curve, but I think, with any types of technology, it's employed in a safe and direct manner with experience and, case observations and trainings. I think it's a way to kind of get this technology out safely.
Okay. Yeah, and Dr. Phu, I know you mentioned laparoscopic. So another good follow-up question to what you just talked about. This person is wondering, what is the difference between laparoscopic, robotic, and then general surgery?
Yeah, I mean, general surgery is just a type of sort of specialty of surgery. And general surgery, I'll just say, I mean, we're at North Penn Surgical here in Lansdale, and we deal with bread and butter surgery like gallbladders, hernias, emergency stuff like appendicitis and cholecystectomies. So that's what general surgery entails, lumps and bumps as well. In regards to sort of the modalities of surgery, whether it's open, laparoscopic, robotic. So open is self-explanatory, right? We make an incision and the old-fashioned way, a big cut, however, whatever needs to be done, whether it's intestines or hernias. And then laparoscopic is sort of like small incisions again, like robot, like we were explaining. However, the instruments are not as I would say mobile or have as much degrees of freedom, like I was describing with the robot instruments. And so you kind of have, it's like working with straight sticks is what we say colloquially. It's like using chopsticks and you kind of go left, right, up and down. You don't have the fine tuning of your fingers or the high definition of the camera. And so it's much more difficult, not impossible, but much more difficult to sew, dissect clearly, and get that articulation is the word I'm trying to say, as much as robotic surgery. So laparoscopy was, starting the late 80s, probably early 90s, as the novel technique for all types of surgeries. And it's, obviously advanced over the decades. So that's what laparoscopy is. And so robotic has been built upon that technology in the sense that it's still small incisions. However, you've got better instruments, better vision, better dexterity, and it does a more precise and accurate surgery for the surgeon itself.
Okay, well, thank you for breaking that down for us. All right, next question here. This person wants to learn a little bit more about the mesh that we talked about earlier. So what are the mesh materials composed of? Are there any issues regarding use of these materials in the body over the long term?
Sure. So there's different types of mesh, different types of materials. Now, some mesh materials are kind of a biologic agent. They're absorbable, but they generally don't leave much behind. We tend to use that type of mesh in more of what I would call like a dirty field, if it was an emergency type of surgery where we needed to close the tissue but didn't want to leave a foreign body behind with a high risk of infection. Most of the meshes that we use for hernia surgery are not actually that type of material. They're actually, best way to think about it is like a plastic type of material. It's very flexible, and as that picture that we showed, Dr. Phu showed earlier, it has, I mean, it's mesh, it has holes in it. And the idea is that your body tissues will sort of grow through those holes, and then that mesh becomes part of your abdominal wall. Essentially, we're patching up the hole, and that's kind of how it's done. Now, long-term consequences, I mean, there's always a chance of long-term problems. Usually we're talking about chronic pain and things like that, but I think the advantage from what I have seen robotically for something like an inguinal hernia, much less chronic pain, because I think we're in a different plane than when we do it kind of the more traditional open hernia, where the nerve might be sitting right where we're working, the main nerves there, and it could potentially sort of scar toward that mesh there and cause like a chronic irritation. Whereas robotically, I think we're just a little bit deeper than that in a space where that's less likely to happen. But certainly that's always a concern. Any type of mesh that we would use inside of the abdomen. So depending on the technique again, but something like a ventral hernia of the abdominal wall. If you put that mesh inside the abdomen, intestines could stick to it over time, which, does lead itself to possible things like bowel twisting or bowel obstruction or something like that. But that also is true of abdominal surgery kind of in general. I think it's a little bit better with certain techniques to try and keep the mesh out of the abdomen. Some of the meshes actually are coated with a special material to try and minimize that type of scar tissue. So we do have various techniques that we use to minimize these types of risks, but those are some of the problems. The only real, I would say, short-term problem with mesh is infection. And I would say, I think as surgeons, we worry a lot about infection, and, knock on wood, luckily we see very little infection. But it's always a problem if it happens, because bacteria kind of growing on foreign bodies, you can't really have great access by antibiotics to non kind of biological tissues like that. So there's always a chance you might have to take that mesh out, but that's extremely, extremely rare. Luckily these days, it's very low infection rates the way that we do these procedures.
Okay.
Yeah, and like Dr. Minkovich said, the mesh is permanent. Very rarely would we use a biologic or dissolvable unless it's like an extenuating circumstance, like an emergency. But yeah, typically it's polypropylene, thermoplastic polymer. Like I say, mesh is usually standard in a repair, because doing a tissue-based repair or a non-mesh repair does lend itself to higher risk of recurrence. So that's why I would say the standard usually, for the most part, a mesh-based repair is what's offered and done.
Okay, well, thank you both. All right, next question here from the audience, and thank you all for submitting such great questions. Feel free to keep them coming. This next question here is going back to recovery time. So I know we touched on this earlier, but this person is wondering if you can go over recovery time again for robotic surgery versus non-robotic surgery. And particularly, they are wondering if recovery times differ.
Sure. So I'll give you kind of my basic spiel that I give patients in the office. So, typically what we're talking about, I break it down into two parts. There's how you're going to feel, and then there's things I don't want you to do. So in the how we're going to feel part of things, it's a little bit variable. I'd say the first couple days, it's always a little bit hit or miss. It depends on the patient more than anything else and just kind of your tissues. But it can vary from very minimal pain to, a good amount of discomfort. But normally 24 to 48 hours is the worst of it. Almost everybody after that 48-hour mark just feels kind of sore, but not in any kind of extreme pain. As Dr. Phu alluded to earlier, we do normally give a small amount of narcotics, but I don't think I have many patients that take it for more than like 2 days tops. The first week, normally about 7 days out, most people are back to like 80, 90%. Usually by about 2 weeks out, almost everybody feels, physically feels about 100%. That's kind of part A. I'd say that those times generally for open procedures are going to be longer. Most people probably are going to feel sore and beat up instead of 1 to 2 days, maybe 3, 4, 5 days, and might not feel back to normal for 2 to 3 weeks. It just depends, and obviously some of that depends on how big the incisions are and everything else. But that's the one part. The things I don't want you to do part, I think, would be pretty similar to both repairs, unfortunately. And what I usually tell people is, no lifting more than about 15, 20 pounds. So a gallon of milk is somewhere in the 10 to 12 pound range. So that's kind of what we're working with for a solid 6 to 8 weeks minimum. And then activity wise, the first 4 weeks, the first month, nothing strenuous. You can certainly do any normal activities, taking the stairs, bending over, reaching for things. All that is 100% fine. But I don't want you doing anything where you're getting your heart rate up. We're not running anywhere. We're not doing anything like that. Once we get about a month out, as long as everything feels good, looks good, there's no concerns. Light, strenuous activity, I tell people is okay. So things like jogging, riding a bike, swinging a golf club, you're getting your heart rate up a little bit, but we're not pushing it. We're not doing anything too extreme. And about 8 weeks out from surgery, as long, again, as everything is healed up, everyone feels back to normal, I kind of lift those restrictions. And what I tell people is like that 8 to 12 week mark, that's when we're going to build back to normal. So don't go from, I haven't done anything for 2 months to, hey, I'm going to go lift 50, 60 pounds. Build back up to normal, take that next 8 to 12 week point to get back to normal strength. And then by about 2 to 3 months, we're back to normal activities, back to normal life, and hopefully not thinking about hernias anytime soon.
Yeah, I have very similar recommendations like Dr. Minkovich. For robotic repair, like I said, he said 2 weeks, it kind of is back to normal, but nothing strenuous. I say, you're encouraged to walk and do light duties and nothing too strenuous, but you're not bedbound. Like you can go up and do your daily activities, it's fine. But very similar weight restrictions. With an open repair, which I do as well, if indicated. I typically push out to 4 weeks of really light stuff, and that's kind of how long it takes for people for an open repair to kind of recover fully. But yeah, in general, what Dr. Minkovich mentioned is what I kind of instruct as well.
Okay, great. Thank you. All right, next question here. This person is going back to our earlier discussion when we mentioned hiatal hernia. So this person says, you said earlier, and I wanted to verify, for a hiatal hernia, a patient would need to see a bariatric surgeon to get repaired. Is this a common surgery, and would it help reflux cough?
Yeah, it's a different entity. I mean, the hernias we're talking about tonight is abdominal wall hernias. A hiatal hernia is like inside your abdomen that's gone through your diaphragm. So hiatal hernia is typically your stomach or part of your stomach that goes through the hiatus of your diaphragm into your chest a bit. And obviously, there's differing severities and degrees of that. That's a hiatal hernia. That's typically diagnosed, either on a CAT scan or an endoscopy. There's usually a lot of tests that are done beforehand to confirm the diagnoses, because sometimes people get reflux or acid and having some upper epigastric chest pain, and so it takes a while to kind of diagnose it. But once you have that diagnosis, yes, the surgery would be done either by a bariatric surgeon or a foregut surgeon who's, specializes in esophagus, stomach surgery. And that could be, either like Dr. Minkovich said, bariatric surgery, foregut surgeon, could even be a CT surgeon. I know a few who does hiatal hernia. So it is a specialized type, but there are people who do that.
Okay, thank you. All right, this next question, we talked a little about this earlier, but wanted to see if you have anything to add on here. Is there any point where you need to move from robotic surgery to open surgery?
There's similar to any procedure. I mean, we're always doing what I would say is the safest thing for the patient at that moment. So if at any point something happens where it's no longer safe to proceed, and whether that's, something like an uncontrolled bleed, let's say, there's bleeding and we can't control it robotically or we can't see robotically, then, the immediate fallback is you're getting a big incision. We're going to get in there, find what's bleeding and stop it. Because obviously at that point, we're talking, that's more from possibly an elective procedure to something that we need to fix immediately. So things like that, are certainly reasons for us to convert. But short of that, I mean, there are I would say it's becoming less and less needed, but there are situations in which, maybe we just don't have good visualization. We can't see well enough that we might be able to see better with an open procedure. I would say that that's pretty rare that we do that, but it's not obviously impossible, and it does happen. In the hernia world, I mean, sometimes an inguinal hernia, groin hernia can be so large that I had one not too long ago where it was not feasible to do it robotically. We just couldn't do it. So, we had to convert to an open procedure, and the patient did fine. And it wasn't, the end of the world, and they still went home the same day, and everything was fine. But, there's certain situations where, we can't, for whatever reason, do it that way. But it's always about patient safety first. If it's unsafe for us to proceed robotically or laparoscopically for that matter, then we will always convert to an open procedure and do it the safest way possible.
Yeah, absolutely. Patient safety number one. And, we want to take care of our patients in whatever way it is. Of course, we always plan and consent that as possible open for the reasons that Dr. Minkovich said, unexpected anatomy, some extenuating circumstance where we can proceed robotically, or even just, the anatomy is odd or changing. So there's a lot of different reasons that could come about, but, possibility of having an open procedure is real. But we always tell patients that beforehand.
Okay, thank you. All right. One other question here that just came through. Is there an engineer in the room to monitor the Da Vinci equipment or device?
So there's not a strict engineer. It's not uncommon for the Da Vinci reps to be around. They're always available. We always have the phone numbers, and I think the OR staff and us as surgeons, we know the rep very well. He's around kind of all the time. So if we have any questions or there's any issues, we can call them. There's an emergency hotline that you can call if there's something strange going on that's not, dangerous, but just something weird. You can always call that hotline and get immediate help. But outside of that, I think we are all trained on how the equipment should function. Not just us as surgeons, but I mean the support staff, the nurses, everyone else in the room. So everyone is well aware of things. If something is abnormal, we kind of know pretty quickly, often before the surgery even starts.
Okay, perfect. All right, and our last question for the live audience, and then I have one question myself to wrap up this evening. But under what circumstances, and this is a little bit more of a specific question here, but under what circumstances would a drain be needed after robotic hernia surgery?
I would say in my experience, usually never, unless there's some situation I'm not envisioning to say you need a drain. Maybe this is a particular circumstance or something extenuating, but for a routine planned elective hernia repair, I would say inguinal hernia wouldn't need a drain. I'm now talking through it. I mean, there could be sort of these big hernias that are done with component separations and like these big, complex abdominal wall reconstructions, which may need a drain in the abdominal wall. That could be a thing, and try to drain out excess fluid, or kind of be in the space to kind of prevent fluid buildup and where the mesh is. So that's kind of where I'm envisioning where drains would be for sort of these higher, complex, bigger hernia repairs. So maybe that's what they were talking about.
Yeah,
Okay.
I would concur. I mean, I offhand can't really think of any reason for groin hernia to need a drain, but sometimes a larger abdominal wall hernia, just for the sake of evacuating blood or fluid, it's rare. I mean, for at least for the procedures that we do. You know, those hernias we're talking about are pretty significant. They're large, and it's kind of a different animal, but patients would know ahead of time. It's rare that, you know, we would place a drain at the time of surgery and not have that conversation ahead of time. So it would be something that would probably be discussed in the office preoperatively.
Okay, well, thank you. And thank you for going through those live questions with us. So with that, I want to ask you one final question this evening as we get to the end of the hour. So my final question for you both is, what are your goals for everyone listening in on this webinar? What would you like our viewers to take away from tonight? Dr. Phu, will go ahead and start with you.
Sure. You know, just want to let the audience know that, of course, you know, see your physician and doctor to, you know, make sure of your diagnosis and correlate it with physical exam if you're concerned about anything. But just to assure everybody, the robotic platform has been used and established for more than 20 years. The robot doesn't operate on its own or is autonomous. The surgeon is always under full control of the instruments and does all the cutting and sewing and everything else that's associated with it. And we're in the room. So in case they're wondering if it's like, you know, something else like an automated machine, rest assured it's not that. The surgeon is there present at all times, as well as the rest of the staff. And robotic surgery is not some, you know, machine that goes off on itself.
Okay, thank you. And Dr. Minkovich?
Yeah, just to piggyback off of that, you know, I know that patients a lot of times have questions about billing, insurance, and those kinds of things. And like Dr. Fu mentioned earlier, I mean, this isn't generally something insurance, from my recollection, at least in the recent past, has had no issues with any procedure that we've even tried to do robotically versus anything else. They just see it as a laparoscopic procedure at this point. We always get procedures pre-approved with insurance companies and everything like that too. So we try and obviously avoid unexpected bills and all that. But all that, you know, even aside, I would just say, just to plug Lansdale Hospital here, you know, coming from a much bigger hospital, I would say that, you know, our hospital here, we're a smaller hospital, but we're very efficient. We have a good team. It's a small team, but everyone knows what they're doing. We pride ourselves on getting patients in and out quickly, and, you know, following up quickly. So, you know, I don't want anyone to think, oh, well, it's a small hospital and a fancy robot, but we have a lot of experience with these types of surgeries. And, you know, we'd love for you to come to Lansdale, and we'll take care of your hernias and gallbladders.
Absolutely. Okay. Well, thank you both. Thank you, Dr. Phu and Dr. Minkovich, for your time this evening. A lot of great information was shared. And thank you all so much for attending and submitting such great questions. I know I learned a lot tonight, and I hope you did as well. We will be posting an event survey, so you can let us know your thoughts. Any other specialties you would like to hear from. If you would like someone to contact you directly to schedule an appointment with a Jefferson Health provider, please fill out the last question in the event survey. And be sure to visit jeffersonhealth.org to make an appointment, stay up to date on upcoming events and webinars, just like this one and more. Be sure to also visit the Jefferson Health YouTube page to view more wellness webinar series events. We have various topics from back pain to robotic surgery to men's and women's health and much more. Recording of this event will also be sent to you so you can rewatch at your convenience. If there is anything anyone here at Jefferson can do for you, please reach out to us. Thank you once again for joining, and please be sure to stay safe and healthy. Have a wonderful night. Thank you.